Greetings and welcome to today's webinar. My name is Elena Kennedy and I'm the Chief Operating Officer here at the Illinois Association of Medicaid Health Plans, also known as IAMHP. Before we can dive into our wonderful presentation today and introduce our panelists, I would like to pause and take a moment to walk through the platform that we at IAMHP utilize so that you better understand how to navigate the control panels so you can also interact with today's presentation. With that, as you can all see, IAMHP utilizes the GoToWebinar platform. As a result, a control panel should have popped up on the right-hand side of your computer screen. On the control panel, you will see an audio tab. By clicking on the audio tab, you will be able to see that you can listen to today's presentation either by your phone or your computer audio. Hopefully all of you should be hearing me by now, but if you or a colleague experience any audio or technical issues, feel free to reach out to me via the questions tab. Questions will be directed to me only. I'll be pulling a few of those for our question and answer segment, but others that are related to technical questions or can be easily answered will be answered along the way. Please disregard our polls or handouts at this time as we will not be utilizing those tabs. However, please direct yourself to our chat function. Our chat function is one of my favorite tools because it allows you to interact with other attendees on the attending today's webinar. Myself, I'm coming up as IAMHP admin or IAMHP organizer, or our panelists. This chat function allows us to create community, dialogue, and interactions in lieu of the fact that we cannot actually be in person due to social distancing measures. I will note that some people will not be able to access the chat function, however, due to firewall protections at either their health plan or their provider office, or due to the version of GoToWebinar they have. We apologize for that inconvenience and appreciate your understanding. Once again, you do have access to audio via the computer or your phone, and please direct questions about audio to the questions tab. Without further ado, and with the logistics out of the way, let's introduce our panelists and dive into our presentation. As noted earlier, my name is Elena Kennedy, and I'm the Chief Operating Officer here at the Illinois Association of Medicaid Health Plans, also known as IAMHP. We are a membership organization for the Medicaid Managed Care Health Plans, and we work with Illinois state government, legislators, advocacy groups, and Medicaid patients and members to invest in and provide high quality healthcare focused on cost-effective, individualized care that helps the residents of Illinois live longer and healthier lives. But as all of you know, improving healthcare delivery systems is a never-ending job, and that is why we work with our members and industry partners to achieve better health outcomes, and which is why we partnered with the Medicaid Managed Care organization, Meridian, to bring this important discussion about maternal health here to you all today. 50% of all births that happen in Illinois are on the Medicaid program, which is consistent across the United States. And so it's so important for us to also engage in a discussion about maternal health. And I am so excited to introduce our first panelist, Dr. Perry. It's always a pleasure working with her. She is the Chief Operating Officer at Meridian Health, and so excited for her to shed some light and also walk through the holistic approach that Meridian takes on maternal health. So with that, welcome, Dr. Perry. How are you today?
Good morning, and thank you. I will just say I'm not the Chief Operating Officer. I don't want that job, but that's okay. I'm the Chief Medical Officer for Meridian Health. And so thank you, and thank you, Elena, for giving us this opportunity to spend the hour and talk about this really important health topic. Before I get started, I would like to introduce the other panelists. Ann Cahill, would you like to introduce yourself?
Thanks, Dr. Perry. I'm Ann Cahill. I'm Vice President of Medical Management for Meridian Health Plan.
Thank you, Ann. Imani Lewis.
Good morning, everybody. My name is Imani Lewis, and I am the Director for Quality Improvement for Meridian Health Plan.
Thank you, Imani. And Paula Brody.
Good morning, everyone. Paula Brody. I'm the Vice President of Support Services with SIHF Healthcare, and I also serve as our Project Director for our Healthy Start program.
Thank you. Thank you all panelists. So, why are we having this conversation today about maternal health? I'm going to start with giving the national perspective and then drill down to what's happening in Illinois. And the reason I selected this topic is because, as you all know, maternal health and birth outcomes, they are leading indicators of health both for our community, our state, and our nation. And quite frankly, we are not doing well. In fact, the United States ranks 33rd out of 36 developed countries for infant mortality, with a national infant mortality rate of 5.9 deaths per 1,000 live births. And this is in contrast to countries like the UK, to France, to Canada, where you're seeing 3.9 deaths per 1,000. And the source for this is the Organization for Economic Cooperation and Development. And when I'm looking at, when we're talking about birth outcomes, what do we mean? And poor birth outcomes. I mean birth defects, preterm births and low birth weights, and those maternal complications during pregnancy, sudden infant death syndrome, and injuries. When we really look at maternal deaths during pregnancy or that first year out, in 2018, the United States again ranked last among developed countries for maternal mortality. And we are coming in at about 17,000 maternal deaths per 100,000 live births. But, those overall kind of national statistics really don't tell the full story, because there are significant racial and ethnic disparities in our maternal and infant outcome measures. So, for example, non-Hispanic Black babies have a higher infant mortality rate at 10.8. This is in contrast to Hispanic babies at 4.9. Non-Hispanic white babies at 4.6, and Asian babies at 3.6. And this, again, is based on infant mortality data from 2018 birth and infant death files. So you can see that there are huge disparities between those babies born to Black moms versus their other counterparts. More importantly, so when you look at the infant mortality and then look at the maternal mortality, that when we look at CDC data, Black women and American Indian Native women are 2 to 3 times more likely to die from pregnancy-related causes than white women. And this disparity actually increases with age, so that by the time a Black woman is in her mid-30s, that rate is actually 5 times higher than her Caucasian counterpart. And we often look at things through the lens of poverty, but that just does not explain it, because a college-educated Black woman has a mortality rate of 5.2 times their white counterpart. And we've seen even in those women who have access to the best care, like a Serena Williams, telling her story of having so many complications and being close to having one of these very poor maternal outcomes during the birth of her daughter. We know that for Black women, that there are huge risks related to thromboembolic disease. We have higher rates of preeclampsia and eclampsia, but there are also other factors that we really just don't fully understand. So though this is a really broad topic, my focus today is really going to be more on preterm births. And the reason for that is that it is the preterm labor and preterm birth that is the second leading cause of those infant mortality data that I mentioned earlier. And it is really an area that Meridian has focused on with both internally as we assess our members and externally with our provider partners. So what is a preterm birth? That's defined as a delivery at or before 37 weeks. And what is low birth weight? So those are babies that are born at less than 2,500 grams. From 2014 to 2016, preterm birth rates rose from 9.57 to 9.85%, and this was both in single as well as in multiple births. In 2018, preterm births and low birth weight accounted for about 17% of infant deaths. And by infant deaths, I'm referring to deaths before that baby is 1 year of age. And those babies who survive often experience prolonged NICU hospitalizations. They often require ventilatory support. And as we all know, they're at much higher risk for readmission after hospital discharge. But the story doesn't just end there. There are so many long-term consequences for these preterm babies, including cerebral palsy, significant developmental delay, hearing and visual impairment, and chronic health conditions such as asthma. So what's the story in Illinois? We're not doing great. According to the March of Dimes 2020 report card, Illinois received a D+ for preterm birth, with a preterm birth rate of 10.7%. Cook County also had 10.7%, and Chicago was slightly higher at 11%. One of the lower birth rates was in DuPage County, which was at 9.1%. And again, significant racial disparities, with Black women having a preterm birth rate that was 51% higher. Specifically, Black women statewide were at 14.5% rates of preterm birth, Hispanic women 9.9%, Caucasian women 9.5%, and Asian women at 9.4%. And what are the risk factors? There are a number of risk factors, and I'm going to kind of go through, sort of the standard risk factors, and then discuss some other risk factors that we may not always look to, but we should be thinking about. So the most critical risk factor for a preterm birth, and actually one of the more predictive, is a prior history of preterm birth. Race, as I mentioned, being Black is a risk factor, multi-gestation, and then there are those structural reproductive abnormalities such as cervical shortening, having had a prior history of uterine surgeries, maternal age, either being younger than 18 or older than 35, and developmental abnormalities in the fetus. Obesity is also a risk factor, along with those other maternal health conditions such as gestational diabetes, being hypertensive, having an autoimmune disorder, or infections. Substance use is also a risk factor, and we know about heroin use and cocaine, but I wanted to spend a couple of moments on cannabis. The studies actually are inconclusive on marijuana use and risk for preterm birth. And one of the things that we are seeing is that with the legalization of marijuana in multiple states, you have women drinking tea, using edibles, etc., to help combat nausea and vomiting. But the reality of it is that, while there is the studies are inconclusive, ACOG has consistently reported that there is really no safe concentration of THC for pregnancy. And while it may be legal, what we know is that, when women are screened for substance use, we should be recommending that they discontinue any use of marijuana, both while they are pregnant as well as if they are planning a pregnancy. And these are recommendations that ACOG has continued to support and continues to make as recommendations in the pregnancy assessment screenings. couple of the other risk factors that we may not pay as much attention to, but we should. Where you live matters. So in a study of paternal poverty, so not maternal, but paternal, Collins et al. Examined the relationship between lifelong paternity class based on neighborhood incomes and looked at that relative to rates of preterm birth. So this study was actually conducted in Cook County, and it took the birth file of infants born between 1989 and 1991 and linked that to their parents born between 1956 and 1976. And what they looked at to determine class was if there were 2 points where the father of the newborn lived within low-income zip codes, and contrasted that with fathers who had at least 2 data points that show that they resided in higher income zip codes. And the outcome showed that men with a lifelong lower class status had twice the preterm rate for births compared to men with a lifelong upper class status. And the thing is that these findings were consistent irrespective of the maternal demographic or marital status. So regardless of whether the mom did not reside in those particular communities and whether the couple was married, etc., that those findings were actually consistent across those groups. Another study that looked at the impact of adverse childhood experiences, called ACE, on the impact of having childhood trauma to subsequent preterm births. Study in 2019 in Wisconsin looked at 1,800 low-income women who were receiving home visiting services and examined the impact of childhood adverse events, including physical or mental abuse, a household in which there was mental illness, or household substance use. And they looked at that woman's childhood experience on her future reproductive health. And the outcomes showed that 84% of women who had at least one adverse child experience noted a 64% higher risk of having a pregnancy loss, a preterm birth, or low birth weight. And Elena has these 2 studies. This was Joshua Mirsky, and the title was Adverse Child Experiences and Poor Birth Outcomes in a Diverse Low-Income Sample. And again, those adverse childhood experiences were those that were being self-reported on an assessment. So how does Meridian approach our maternal health, and how do we approach impacting preterm birth? So the first is identification, then activation, and then collaboration. So for identification, and of course we are member-centric because we are trying to ensure that our moms have the healthiest birth experience, pregnancy experience, and a healthy baby. So to identify, we utilize what's called the notification of pregnancy, and I'll dive into that a little a little later in the presentation. Through that notification of pregnancy, there's a risk assessment, and then a care management intervenes on those women who are at high and moderate risk. Activation, making sure that women are actively engaged in their pregnancy. You know, one of the things that is important is for our moms to understand each pregnancy is different, whether this is your first or your 4th or 5th. Each pregnancy is different, and there is a need for prenatal care and education and assessment with each baby. Part of our activation is a robust member education. We have a maternal health concierge, and then a member incentive program. And then collaboration. Because again, how can we get those services that our moms need? Well, we need to collaborate with our providers, and also we need to collaborate with the community, because this mom is not just in isolation. She is part of a broader community, and we need to also work to impact the services within that community. The title of Meridian's maternity program is called HUGS. And the goal for HUGS is better health outcomes. And again, because we are a managed care organization, we also look at those better health outcomes at lower cost. And what are the health outcomes that we're trying to improve? We focus on improvement in prenatal, postpartum, and well child care. We're looking to actively decrease our preterm and low birth weight deliveries, and then looking to decrease our NICU admissions and those lengths of stays. And we know that by improving care and health outcomes, that this will also result in improving cost savings. So what are some of the benefits of this maternity risk management? As we all know, early and regular prenatal care helps identify those conditions and behaviors that can result in preterm and low birth weight babies. Our pregnancy management programs also help to improve those birth outcomes. And again, early identification of a pregnant woman and also early identification of those risk factors is also important. So a little bit about our notification of pregnancy. Our notification of pregnancy, which we call the NOP, is essentially a tool which identifies that one of Meridian's members is pregnant. And anyone can submit this. It doesn't just have to be the provider that's rendering the service. It can be the member herself or a Meridian staff member. And what the NOP does is that it lets us know the due date. It's also an assessment tool that lets us know certain risk factors. And what's also important is it updates the contact information. As everyone on this call knows, one of our challenges is making sure that the contact information that we have is correct. The NOP also, along with claims data, helps to stratify our members into low risk, medium risk, and high risk. And based on that stratification, women are prioritized for outreach. Lastly, part of our in activation is member engagement. All pregnant Meridian members are enrolled in outreach initiatives from that identification of pregnancy, that NOP, through actually 8 years postpartum. And that's one of the things that we did at the end of last year, which was to extend the time for which we continue to outreach our members after delivery. And the strategies that we use are member texting, educational materials, call campaigns, and invitations to community events such as community baby showers and childhood immunization promotions. Pre-COVID, we had annually, we had in-person community baby showers, which were not just for Meridian members. They were held throughout the state, and we actually worked with our provider partners to invite any pregnant women and their partners to come participate, get educational information, understand about the importance of prenatal care, car seat safety, and then we gave a lot of swag, a lot of gifts to those members. So participation, that was pre-COVID. After COVID, we're doing virtual baby showers, where instead of being in a group setting, it's more that women come from the community along with our members, but in a more staggered fashion, but also receive that information. And first of all, is there anything you wanted to add about the care management component?
Thanks, Dr. Perry. The only thing that I think that I would underscore is the whole goal of our program is really education for our members, for our pregnant members, and a strong connection to their provider, because prenatal health and postnatal health is so important for optimum pregnancy outcomes. So through our texting, through the educational, through our connection and engagement in care management, we are constantly encouraging that the member attend their prenatal, postnatal visits and obtain the care that they need, both for themselves and for their babies. Thank you.
Thank you, Ann. One of the other critical components and some of the kind of best practices we wanted to share were our incentive programs. And Imani, would you please speak to that?
Sure. So we have a member and a provider incentive program. For our members, we have found that the best practice is not only incentivizing our members with rewards or certificates, but also being able to give our members actual supplies that they can use once the baby has arrived. And so initially, our gifts, or such as a stroller, a cribette, diapers, things like that, we would offer to the members once they've completed their prenatal and postpartum visits. But what we found is once they've completed their postpartum visit, they no longer have the demand in getting those gifts, that crib or that stroller or that car seat, because they already have it since the baby has already been born. So what we did was we moved that incentive up to just for the member once they've completed their prenatal visit. So now they're able to get those additional gifts and prepare for their baby before the baby is born. So that is one of the best practices that we've been able to transition to over the past year. For our provider incentives, one of the best practices that we've noticed is making sure that we're incentivizing the servicing provider and not necessarily the primary care provider. We do know with women, in many instances, the PCP and the OB gynae can be the same person, but sometimes it's not. And so we got some direct feedback from providers saying, we think it's best you actually incentivize who's completing these prenatal and postpartum visits. And so instead of just looking at the PCP, we're looking at who the servicing provider is and making sure that that servicing provider is the one who receives the incentive. Thanks.
Thank you. So we're going to switch focus and talk about a bit about our collaboration with our providers, specifically our collaboration in Metro East. Two of the larger counties in Metro East are St. Clair County, which lies on the Mississippi River right across from St. Louis and has a population of about 259,686, and that's based on 2019 census data. Of that population, 30.6% is African American, and 13% of the population lies below the poverty level. Madison County, which is the other large county in that Metro East region, has about 263,000 members, of which 8.8% of the population is Black, and 10.9% of the population lies below that poverty level. For both of those counties, based on public health data, both Madison and St. Clair County have seen the same increase in preterm births that we're seeing both statewide and nationally. So back from 2011 to 2012, the preterm birth rate and low birth weight was 8.2% for Madison County, and St. Clair was 9.0%. And for 2017 to 2018, that rate was 9.5% for Madison County and 10.4% for St. Clair. Specifically for St. Clair County, the birth outcomes ranked below Illinois for infant mortality, low birth weight, and preterm birth. And again, those outcomes are even more acute when we look through the lens of racial disparities, with, again, Black women and Native American women having higher incidences of preterm births and poor birth outcomes than their white counterparts. So we had the opportunity to partner with Southern Illinois Healthcare Foundation to see how we could improve the birth outcomes and the birth weight and decrease the occurrence of preterm births within a population. And so I will turn this over to Paula Brody to talk about Southern Illinois Healthcare's prenatal nutrition program.
Thank you, Dr. Perry. Good morning again, everyone. For those who may not be familiar, SIHF Healthcare, we are a federally qualified community health center providing services in 11 counties in Southern and Central Illinois. We are also a federally funded Healthy Start grantee, and our Healthy Start program focuses on reducing infant mortality and reducing racial disparities in perinatal health. Our SIHF Healthcare is the recipient of a grant from Centene to address racial disparities in maternal child health and birth outcomes by reducing food insecurity and increasing healthy eating. In this project, we have partnered with the Sweet Potato Patch to implement the prenatal nutrition program, which provides healthy meals and nutrition for pregnant women. The Sweet Potato Patch is a Chicago-based food business whose mission is to increase healthy food access to residents in urban food deserts. The Sweet Potato Patch staff, they deliver farm-to-table healthy meals directly to residents. And I like to describe them or think of Sweet Potato Patch as the HelloFresh or Blue Apron for food deserts. The goal of our Healthy Start program, of our prenatal nutrition program, is to promote healthy pregnancy and address those disparities in birth outcomes among SIHF African American prenatal patients by increasing their access to healthy food and consumption. And what led us to this project was that we saw, beginning in 2018, and we saw it again in 2019, an increase in our low birth weight. And on the screen there, you see that in 2019, the baseline for all birth of all races was 11%. But among our African American patients, low birth weight was at 17%, 16.6. And for our white patients, that number of low birth weight was at 7%. So the African American weight, that disparity was doubled for our African American patients. So that is what led us to this partnership and discussion with Centene for prenatal nutrition. And as we dug into looking at what was behind some of the low birth weight of our African American participants, we saw three areas that were impacted. One, many of the women who had a low birth weight, they also had a diagnosis of preeclampsia, also of intrauterine growth restriction and obesity. And we know that food, diet, and nutrition are tied to all three of those diagnoses. So with our intervention, we really wanted to look at something that was different, that we were not doing, and something that could help with the social determinant of health as related to healthy foods. So with our prenatal nutrition program, our partner Sweet Potato Patch provides healthy meals and nutrition education to SIHF prenatal patients who choose and select to enroll in our prenatal nutrition program. When they enroll in the program, participants receive heat and serve meals that are ready. They just need to pop them in the microwave, and the meals are delivered to their homes each week. Each participant receives 10 meals a week, and those are lunch and dinner meals. And the meals are delivered on Thursday, Friday, and Saturday. And so the moms get the opportunity to choose which day of the week of those 3 days they would like to have their meals delivered. And we use Saturday sort of as kind of a catch-up day also. So if we did happen to miss someone on that Thursday and Friday, if they were scheduled, we try to go back on that Saturday and also try to redeliver on those days. So who's enrolling and participating in the new prenatal nutrition program? They are SIHF prenatal patients, and we put the program for SIHF patients because when this, at the end, we want to be able to look at and compare the outcomes of the moms who are receiving the meals and compare those to the moms who did not receive meals. They are African American. We want them to enroll in the nutrition program early in the pregnancy before the 3rd trimester. So we recruit them in their 1st and 2nd trimester. Singleton pregnancy, so we do not have any moms who have are pregnant with twins or triplets at this for this program. And also they need to live in either Madison or St. Clair County. And we chose those 2 counties because that is the counties which have the largest percentage of our African American prenatal patients. How do women know about the program and get enrolled? They are referred to our program coordinator by the moms are by their healthcare provider. They are also invited to participate in the program by the program's coordinator who visits the various health centers. And then also we have Healthy Start case managers who are located in several health centers as well. And so they also talk to new prenatal patients about the program and invite them to participate. Now, each mom who enrolls in the program completes a pre-test and a post-test regarding food consumption, such as fast foods, snacks, fruits, sugary beverages. The pre-test is completed before they receive their first meal delivery. And the pre-test, I believe, it's a pretty comprehensive pre-test. It's about 8 pages long and takes about 15 minutes for them to complete with their coordinator. And then the post-test occurs after they deliver during the postpartum period. Our evaluator for this project has completed a preliminary analysis of the first 30 pre-tests that have been completed by the moms in the program. So I'll just share some of that analysis with you. Almost half of the moms who completed the pre-test were positive on food insecurity screen. Almost half of the moms stated that they never use a grocery list when grocery shopping. And more than a third of participants never compare prices before buying food. And that was listed twice, but we can skip the next. Also, from our first 30 pre-tests, we saw that on average, moms reported eating food from a convenience store or gas station shop almost 3 times a week. And they reported eating burgers and fries from a fast food restaurant almost 2 times a week. And I know when I was talking with some of our staff, and I think even Dr. Perry mentioned, well, you would think they would eat more from a fast food than they do from a convenience store. But in our communities in East St. Louis and Cahokia, we have not fast food, we have convenience stores on every block. And those convenience stores sell pizza, chicken wings, hot dogs, So it's very convenient. Compared to fast food, in East St. Louis, we only have one McDonald's, and it's not centrally located. It's not in an easy part to get to, so it's not convenient. And I think in our Cahokia community, we have one McDonald's and maybe one Taco Bell. These convenience stores that serve a lot of unhealthy food are easily accessible to the community. And not surprising, the moms reported the main reason for choosing fast food or convenience stores is convenience. It's fast and it's quick. And also their children like the fast food. Also, from the first 30 pre-tests, we found that the moms on average are drinking soda with sugar about 3 times a week, drinking sugary juices 4 times a week, and for unhealthy snacks, potato chips and candy on average about 4 times a week. Currently, we have 50 participants who are receiving meals. And below you can see the breakdown of those ages of participants. Our recruitment for the program has been steady. You know, it's not a hard program to sell, you know, to get these delicious meals that are already prepared delivered to your home. Our moms are excited and look forward to receiving and want to participate. So we have a high acceptance rate. So we're pleased with the recruitment and participation of the moms and working with Centene and Sweet Potato Patch on this innovative project. Thank you, Dr. Perry.
Thank you, Paula. I think also we've had some lessons learned early too, is that some of the women have asked for, first of all, they've been really excited about the program. And also since they have a coach from their community, it's also learning how to prepare meals for your family with items purchased at stores within the community, so that we're not, you know, Sweet Potato Patch isn't asking for ingredients that would be really difficult or so expensive that you couldn't get it, and that ultimately we hope that one of the outcomes of the program is that not only are we impacting this mom and her future baby, but also impacting her family as she brings those healthier eating habits to her children and to her community. So I want to, you know, again, we are thrilled to be able to partner and learn actually from our members and from this community and through this partnership. So I would like to close by saying, you know, first off, thank you to Elena and Samuels Fry and IAMHP for allowing us to share our information and our collaboration with SIF. I want to thank all of the attendees, but more importantly, I think that as we get more and more information and really start to understand why we have these racial and ethnic disparities, that we're able to assess our members, intervene with our members earlier, and then ultimately help to improve these birth outcomes for our state. So with that, thank you so much, and that concludes my presentation. Elena?
Thank you so much, Dr. Perry, and to all of our panelists for this fantastic presentation. I have to say my hand is cramping up a little bit. I was writing so many notes. I really found this to be very informative and very interesting, and I hope all of our attendees also found it just as riveting. With that, we are moving into our question and answer segment of today's presentation. Should you have questions, please submit those via the questions tab or the chat function, should you have that tab. One of the things that I also just wanted to say, I found so fantastic was that last point you made, Dr. Perry. Obviously the ability of a mother to provide, nutrients for her baby is critical in fetal health and for survival. And when we're talking also for maternal health, but I love that note about, this program also invests in families, and that children, and elevating the whole family, and really wrapping our arms around, mom, baby, and other children who might be living in the household. We know also mothers might be living with extended grandparents or aunts and uncles, and how do we just elevate the health of the whole family in this experience? And so I really appreciate your approach. We did receive a question about the maternal health concierge experience, and I think some of our attendees are just looking to learn more about what is that, and what does that mean for Medicaid members. So can someone walk through Meridian's maternal health concierge? Oh. Can someone hear? Can everyone hear me?
Yeah.
Oh,
I'm sorry, Dr. Perry.
Oh, I'm sorry. I
Okay.
was on mute. I was saying, Ann, would you like me to take that? I'm sorry, I was on mute.
No worries.
So we have a texting program that gives all of this information to women, and part of the maternal health concierge is having live chat. So that live chat is a care manager who is available to answer questions in real time. And then if they can't answer it, forward that information, or if the question's about resources, linking that mom into those services, rather than saying, getting that information for her. And so it's more of a real time rather than, a delayed response. And so it's kind of that give and take, and being able to have those questions answered in real time. Ann, did you want to add anything to that?
No, you know what? You covered pretty much everything that I was going to touch on as well. Thanks.
Yep. And the maternal health concierge supports also our high-risk care management, maternity care management program. And so for that program, we have RNs who are with an OB background, who are helping to outreach and support our higher and moderately high-risk women. But if a woman is answering questions or asking questions that may indicate that despite what we know about her, she may be higher risk, that maternal health concierge can also link her to, to get more questions, or forward that on to see is there additional information that we either didn't pick up in the assessment, wasn't disclosed, or things have changed, etc. So, yes.
Well,
and that
I
actually
really
is something relatively new for us. So we are learning more and more and seeing just how that works out. Again, trying to make a difference, trying new things to see how we can support our members.
Well, I love the program. It feels very white glove experience, really making sure that we're connecting to the member, and we look forward to learning more about how that unfolds. Let's dive in to the program at hand and the meals program a little bit further. So I know that we're in the preliminary process, and I know that we're still getting information and data, but is Meridian looking to expand this program into other regions of the state based off of the experiences so far? What are your high-level thoughts?
So right now, actually, we're looking to see kind of how things play out here at SIF. We would love to be able to look more broadly, but right now, we had a few fits and starts, just, as it takes to get all the paperwork done and getting women engaged, et cetera, and then to see, well, does it make a difference? You think it does, it should, but will it? So Meridian is always interested in looking at provider partners, and I will say it depends on the right partner. We are working with an investigator with Southern Illinois Healthcare Foundation, and I will say from the CEO down, because it takes a lot of leadership to be an engaged partner. So there can be the want without the engagement on a leadership perspective. And so what SIF has done has been an amazing partner. Paula and I communicate every other week just on how things are progressing. You know, we have a goal of having having a minimum of 125 women in the program. You know, again, so that program the program that we currently have is still growing. But again, we are still looking to see how can we maximize this program, and also what do women need? You know, despite having a focus group looking at meals, we've had a lot of lessons learned. You know, what were the best days for meal delivery? Some things that might seem, I believe there was an issue with, not an issue, but one of the meals was a ginger chicken, and a number of women had never had ginger. And we're wondering what was that? They liked it, but what was it? Why would I have this? I would never make this. And so sometimes it's also getting women to try new things that you haven't been exposed to. Again, a lot of work with Paula's team and the team that outreaches and engages these women. So the short answer is we're looking to see how we can grow this program. But yes, we are open to also relationships with other providers within the state that are servicing our members.
Wow, I think that's really interesting, your comment about the ginger chicken and just providing that open dialogue also to connecting with the members so that they have a voice at the table and they can communicate their experiences also back. You know, so it's a living program. It can adapt, and you can also gather information in real time. But when does Meridian anticipate to get preliminary results from the program? When do you expect to kind of see more of that harder data instead of just?
I get an update from Paula every 2 weeks with where we are and how we're enrolling the members. So it is kind of ongoing. Paula, did you want to add anything to that?
Yes, I will say the program started in mid-November. So, you know, that the outcomes and the results, we have to wait for those moms to deliver and complete the post-test and do the analysis. So we're really kind of right in the beginning of the program at this point. The analysis that I shared was just the evaluator. We do have an independent evaluator. So when this project is complete, so I'm assuming, you know, it will be, you know, later in the year or early next year, because the moms have to deliver. And then we will be pulling their data and then doing the pretest and then doing the analysis of those participants in the program. So we're really just about 6 months into the program.
I also wanted to add one other thing, Elena, is that in addition to the nutritional aspect, we're Paula's team is also screening women for smoking and for WIC use. So one of the other program goals is, you know, decreasing the women who are smoking, making sure, one, they're educated, understanding the impact of smoking on, you know, intrauterine growth retardation and preterm labor. And then also making sure women are aware and understand about WIC and the importance of WIC. So this is really a comprehensive program. The meals and understanding the importance of delivery are just a part of that. And what we've learned is, again, this has been such an iterative process from, do we have group nutrition education versus individual? How do women feel about coming together and acknowledging kind of what some of the habits are versus is that better in a one-on-one setting? So as Paula mentioned, this is a program that started in November. We're learning a lot. And so, and how do we maximize and improve the outcome? You know, we're operating on the premise that if you improve how a woman eats, we're going to get a better outcome. And if we are able to, you know, decrease some of those other maternal risks in terms of smoking, that will get a better outcome. But right now, again, none of those women have delivered yet. So, you know, we don't have that hard data.
No, but I think that's helpful also for as we continue. Oops. Sorry about that. I got some feedback on my end. I apologize. Yes, I think that's really helpful to note. It sounds like the process is also, you know, very engaging with the women, and also, you know, getting their feedback, their opinions about the process. With that in mind, were the women within the region, or were women with lived experience a part of the preliminary planning process? And within that, how were some of the meals selected, or why were 10 meals selected? You know, was that based on input from the women in the community, or providers, or information that you were seeing in studies? What informed that work?
So I know that, this is Dr. Perry, and then Paula, please chime in. I know that there were focus groups and a selection. So they were focus groups of women within the community to say, these are some of our suggested meals. What do you think about them? Because what was known, and I will share that Sweet Potato Patch is it's an African-American woman food nutritionist, Stacy Miner, that owns that company. She is a native Southside Chicagoan, and one of her concerns was making sure that meals were culturally appropriate, but not just that, is it something that women are going to eat? We've got to make it healthy, and it's got to be something and nutritious and that women will eat. So there were focus groups that evaluated meals and determined, yes, we like this, no, this is a maybe, and based on that focus group outcomes help to inform, you know, some of the meals that would be prepared. But again, women were also told that if you're getting meals and you don't like them, despite what a focus group has said, and a focus group of women from your community, that, you know, we will always be willing to work and change that to things that you enjoy. Specifics to the meals, Paula, and the number of meals, can you speak to that?
Yes. We chose to go with 2 meals a day to be able to give the moms flexibility and have a choice of what they had on that third meal. So it's a lunch and a dinner meal, and giving them that flexibility again, so that first meal of the day could be what they choose to be, what they wanted that to be. And I did want to add, Dr. Perry, you mentioned the focus groups, and we also did a meal tasting where the Sweet Potato Patch came down and actually made several meals for the moms to try. And also, even in delivery now, the meals, the Sweet Potato Patch staff, they're very flexible. We have a couple of moms who want to become meatless meals. So they've made adjustments for those 2 moms. We also have 2 moms who had bariatric surgery. So they have a different type of diet they need to follow. They've been able to make adjustments for them as well.
Well, I just have to say, I am so grateful that we took an hour out of our day today to meet with our wonderful panelists as they walk through maternal health and their holistic approach. But one of the things that just really continues to strike me, and one of the things that I really see as a through line through this presentation, is really putting members at the core. Making sure that they have a voice at the table, making sure that they can advocate for themselves, making sure that they are empowered through this process. You know, it really coming down to the fact that there was even tastings, and you could choose to have meat or not to make sure that they were also just learning throughout this process about what is this ginger or whatever it is, just really empowering these women to have a voice is so amazing. And so I really appreciate you all of our attendees taking an hour to learn about this, but also to our panelists for educating us. With that, yes, we will be sending a recording of this presentation to all of our attendees. And should you want to get in touch with any of our panelists, please reach out to me. I'm already receiving a lot of people who are looking forward to furthering this partnership and learning more about Meridian and the work that's going on in maternal health. Additionally, please fill out our survey, our post-webinar survey results, so that we can continue to learn and adapt and bring more presentations that you all find helpful. With that, please like and share us on Facebook, LinkedIn, and Twitter, and please sign up for our newsletter and our other informational so you can find out about more webinars like this. With that, we are at time, so I will have to end today's presentation, but once again, thank you to all of our attendees and our wonderful panelists, and we hope you have a lovely and great day. Goodbye.
Thank you.